Meet Pete. He's a 49-year-old construction worker coming in for evaluation of his epigastric pain that he has been having for a few months, particularly at night. He reports the pain is associated with heartburn, a feeling of reflux, and occasional nausea. He hasn't needed to throw up because of it, though. He states that the pain actually gets better after he eats a little something. So he finds that when the pain wakes him up in the middle of the night, that having a little snack helps and he can get back to sleep. Given this, he notes that he's been gaining weight over the past few months. He reports being an active smoker even though he's been trying to quit. He proudly reports that he isn't taking any prescription medications, but because of his construction job, he finds he has to take ibuprofen a few times a week for joint pain. He isn't as young as he used to be. Epigastric pain? Well, the differential is just huge for that. But we're given a big clue. It's better with eating? That's odd. Based on this, you astutely send the patient for an EGD. And the report you receive from the gastroenterologist is that there is an ulcer in his duodenum, relatively normal appearing, no evidence of bleeding, and no biopsies were taken. So in this clinical case, we're actually given the diagnosis. That's nice, but we are asked what the next step in management is. And that's where things get complicated. But before we get to management, let's talk about ulcers. Peptic ulcer disease, or PUD, was once a common indication for GI surgery, but has become both less prevalent and less severe in the last 30 years. However, even with improvements in detection and treatment, peptic ulcer disease remains a significant source of morbidity and mortality, and, as such, it's definitely worth knowing about. Check out our construction sketch. These guys are going to help illustrate as we work through PUD. We'll start with defining peptic ulcer disease. A peptic ulcer involves acidic erosion through the muscularis mucosa layer of the gastrointestinal tract wall, which is why these guys are jackhammering through the layers of all this concrete. Anything more shallow is technically called an erosion, and erosions are seen fairly frequently in most causes of gastritis. Let the pattern on the floor remind you of the stomach and duodenum. Peptic ulcers can occur either in the stomach as gastric ulcers or in the duodenum as duodenal ulcers. Duodenal ulcers are more common of the two. Development of peptic ulcers can be the product of increased acid production, decreased mucosal protection, or both. In all of these cases, the most common risk factor for development of peptic ulcers is the Helicobacter pylori infection, which is associated with 90% of duodenal ulcers and 70% of gastric ulcers. The second most common cause of peptic ulcers is the usage of NSAIDs. Pete from our clinical case says he uses some of these occasionally, but not too often. Just to be safe, we should counsel him to try some Tylenol instead. Ulcers due to NSAIDs occur due to the loss of prostaglandin-mediated protection of the gastric and duodenal mucosa. Remember that NSAIDs inhibit cyclooxygenase, or COX, which is the rate-limiting step in prostaglandin synthesis. When combined with H. pylori infection, there is a synergistic effect, and patients are much more likely to end up with ulcers and complications from ulcers. A much less common cause is Zollinger-Ellison syndrome, which is caused by a gastrinoma, a pancreatic neuroendocrine tumor that secretes gastrin, the hormone responsible for gastric acid production. Unregulated gastrin production leads to a markedly increased acidity of the stomach, and thus ulceration. While pretty rare, gastrinomas should raise a red flag for multiple endocrine neoplasia type 1, which involves the 3 Ps: pituitary, parathyroid, and pancreatic tumors. Other causes of ulcers include anything that can cause gastritis, including stress-induced gastritis. While Pete's construction job is definitely stressful, that's not quite the kind of stress we're talking about. Stress-induced gastritis occurs in very ill ICU and hospitalized patients. Other associations with ulcers exist with cytomegalovirus, abdominal radiation, and brain injury in burn patients. For more on these topics, check out our sketch on gastropathies. Smoking is a big risk factor for PUD. It will exacerbate symptoms and worsen progression. but it does not cause peptic ulcers. Other risk factors include alcohol use, steroids, and age. Let's get Pete some information on how to stop smoking. Oh, geez, that's gonna bruise. The most common presenting symptom of PUD is epigastric pain. The relationship between pain and meals may give clues as to whether the ulcer is duodenal or gastric in location. Oh, yum! I bet they have some tasty tacos over there. Remember that EGD they did in the clinical case? Good thing Pete's ulcer is in the duodenum. Duodenal ulcer pain is decreased with meals, likely due to the buffering effect of food as it enters the duodenum, as well as alkaline pancreatic secretions stimulated by the presence of food, both resulting in decreased acidity of the duodenum. When there is no food, gastric acid passes through the pylorus and hits the wall of the duodenum, which does not have the same acid protection that the stomach does, causing increased pain in any ulcers that are present. Although, with his symptoms, tacos may not be the best thing for Pete to eat. Gastric ulcer pain, on the other hand, is greater with meals, due to both mechanical irritation and increased acid production as a result of food entering the stomach. Without food, there is less acid that needs to be produced, and therefore there is less pain. Though epigastric pain is the most common symptom of PUD, up to half of patients will complain of heartburn or other dyspepsia symptoms as well, including upper abdominal fullness, nausea with or without emesis, reflux, regurgitation, and excessive belching. Guess that helps explain Pete's other symptoms. Ack! Jimbo, look out! Clueless Jimbo, happily whistling to himself over here, is missing the fact that he's got a giant ulcer. I mean, a giant hole that he's about to walk into. In up to 70% of cases of PUD, there are no symptoms whatsoever, and patients may present initially with a complication of PUD, be it melena or hematochezia from acute upper GI bleeding, sudden severe pain from ulcer perforation, or acute gastric outlet obstruction. If the patient has any alarm symptoms, esophagogastroduodenoscopy or EGD should be the first test to make sure nothing too serious is going on, like cancer. Luckily, Pete already has had an EGD. Alarm symptoms for PUD include weight loss, dysphagia, odynophagia, iron deficiency anemia, persistent vomiting, or a family history of GI cancer. In patients over 60, new onset symptoms of dyspepsia, such as new epigastric pain, upper abdominal fullness, heartburn, nausea, or belching, is another situation which should prompt EGD. In patients without these alarm symptoms, EGD is not necessary right away. Imaging, like CT, or radiography with oral barium contrast, may be performed during workup of the abdominal pain. Definitive diagnosis of ulcers is made by direct visualization of the ulcer on EGD, but this may be delayed in patients with imaging suggestive of ulcers without any alarm features. In patients with PUD, either suspected or definitively diagnosed, H. pylori should be tested for. Aha! So here's the answer for our clinical case. Pete already had an EGD performed, but remember, there were no biopsies taken. So we need to do some tests for H. pylori. Oh gosh, that helicopter looks like it's got some bad breath. Or at least some bad gas. Because H. pylori involvement is so common in PUD and is easily treated, H. pylori testing is a common first step in management of PUD. The best non-invasive tests for H. pylori infection are the urease breath test and H. pylori stool antigen. Serology is possible, but no one really uses it anymore. If H. pylori testing comes back positive in patients with PUD, treatment for eradication of H. pylori is initiated. A combination of acid suppression with a PPI, usually omeprazole, and antibiotics, either clarithromycin plus amoxicillin or clarithromycin plus metronidazole, should be given for 2 weeks and then stopped. You may hear this called triple therapy because there are 3 total medications given. Eradication of H. pylori should be confirmed at 4 weeks by checking for active infection by repeating the urea breath and stool antigen tests. It's important to remember that PPI may cause false positive results. So after the 2 weeks of therapy, the PPI should be held for 2 weeks prior to eradication testing. Even though these fancy folks are happy their H. pylori is treated with their purple parasol PPI and antibiotic top hat, they don't seem too pleased with the progress on construction of their fancy new hotel. If H. pylori testing comes back negative, the patient should be treated with a PPI for symptom control, and lifestyle changes should be made to remove offending agents. This means stopping or reducing NSAID use, smoking cessation, and decreasing alcohol consumption. For patients in which NSAIDs have to be continued, such as treatment of osteoarthritis in order to avoid steroids or opiates, or aspirin for coronary heart disease, chronic PPI therapy can help prevent PUD progression. Medical therapy, including eradication of H. pylori and anti-acid therapy with PPIs, is almost always effective treatment of PUD. However, for the uncommon times that medical therapy doesn't cure PUD, an EGD is the next necessary step. Remember that EGD is also indicated in patients with any alarm features, as we already discussed, as well as patients with evidence of any gastric ulcers. On EGD, benign peptic ulcers have a flat base, rounded edges, and smooth appearance. Because of the high incidence of gastric cancer, all gastric ulcers should be biopsied when seen. Duodenal ulcers, on the other hand, only need to be biopsied if there are suspicious findings, including an ulcerated mass, heaped up irregular ulcer margins, or irregularities in the folds of tissue surrounding the margin. So remembering back to our clinical case, Pete didn't have any biopsies taken of his ulcer, which is good management as it had a classic appearance and was in the duodenum. For both gastric and duodenal ulcers, antral biopsy should be performed for tissue urease testing. This is the gold standard of H. pylori infection diagnosis. If EGD with this biopsy is performed prior to other H. pylori testing, that testing does not need to be repeated prior to eradication therapy. So, in our clinical case, an astute gastroenterologist should have taken antral biopsies. Then we wouldn't have to perform the urease breath test or the stool antigen test on Pete, and we could get right to treatment. Refractory peptic ulcers, especially in the setting of multiple ulcers, or ulcers distal to the first and second parts of the duodenum, should raise suspicion for Zollinger-Ellison syndrome or ZES. ZES consists of the triad of elevated gastric acid secretion, peptic ulcers, which are often multiple, and a gastrin-secreting gastrinoma. Patients are typically diagnosed by measuring elevated gastrin levels in the setting of hypersecretion of gastric acid. Diagnostic gastrin levels are a whopping 1,000 nanograms per milliliter or greater. All patients diagnosed with ZES should be screened for MEN1, due to the high association between MEN1 and ZES. Another cause of refractory PUD may be hypercalcemia. Calcium increases gastric acid secretion by indirectly increasing gastrin secretion and directly stimulating parietal cells themselves. When evaluating refractory PUD, it's important to measure serum calcium levels to exclude hypercalcemia from hyperparathyroidism, sarcoidosis, or other granulomatous diseases as the cause of ulcer formation. If the EGD discovers a benign ulcer, it should be treated with PPI. If the EGD biopsy shows continued H. pylori infection, a new antibiotic regimen for H. pylori eradication should be given, and testing for successful eradication should also be performed. On EGD, if there are very small uncomplicated ulcers and symptoms resolve with therapy, well, you're all done. No further questions, Your Honor. For most other ulcers in patients who remain symptomatic, you should repeat endoscopy after 12 weeks of therapy. Check for ulcer healing, and if gastric, check for cancer again. And biopsy to check for H. pylori again. I mean, you're in there, you might as well. Many patients with refractory ulcers will remain on maintenance PPI therapy. When does surgery come into play, you ask? Surgery is indicated in two situations. First, if any complications of PUD arise, including acute upper GI bleeding, perforation, obstruction, or in cases of malignancy. And secondly, surgery acts as last line therapy. For ulcers refractory to medical therapy, there are several different surgeries that may be performed. Since the indications for the different type of surgery are dependent on the patient, symptoms, anatomy, and even surgeon preference, we aren't going to cover them during our sketchy internal medicine course. That's about it for now. Let's summarize. Peptic ulcer disease, or PUD, is where ulcers are present in the GI tissue, typically in the stomach or duodenum. Once erosions progress through the muscularis mucosa layer, they are considered ulcers. Duodenum ulcers are more common than gastric ulcers. Peptic ulcers can be caused by Helicobacter pylori infection, NSAID usage, which decreases mucosal protection, or more rarely, Zollinger-Ellison syndrome, which is from increased acid production. Smoking may exacerbate symptoms. Epigastric pain is the most common presenting symptom. Duodenal ulcer pain is decreased with food ingestion, while gastric ulcer pain is greater with food ingestion. Other symptoms include heartburn, upper abdominal fullness, nausea, reflux, and belching. Up to 70% of PUD may be asymptomatic, in which case they may present initially with a complication, which could be acute upper GI bleeding, ulcer perforation, or acute gastric outlet obstruction. The presence of alarm symptoms should prompt EGD immediately to rule out cancer. These alarm symptoms include dysphagia, odynophagia, persistent vomiting, weight loss, iron deficiency anemia, and a family history of GI cancer. New onset dyspepsia symptoms in patients over 60 should also prompt EGD evaluation. Patients with evidence of ulcers should undergo non-invasive testing for H. pylori via either urease breath test or H. pylori stool antigen test. If a patient undergoes EGD, antral biopsies should be taken for H. pylori testing. If H. pylori testing is positive, treatment consists of PPI therapy with 2 antibiotics, clarithromycin and either amoxicillin or metronidazole, for 2 weeks, and then repeat testing to confirm eradication at 4 weeks. If H. pylori testing is negative, PPI therapy should be initiated and other lifestyle modifications should be made, such as smoking and alcohol cessation and stopping NSAID usage. For all cases of refractory PUD, EGD should be performed. Gastric ulcers should always be biopsied, and suspicious duodenal ulcers should be biopsied. In cases of refractory PUD, Zollinger-Ellison syndrome should be suspected and ruled out. ZES is more likely in cases with multiple ulcers, and ulcers in the distal duodenum. ZES is diagnosed by gastrin levels. Hypercalcemia should also be suspected in refractory PUD, and serum calcium levels measured. If benign ulcers are present, they should be treated with PPI, and if EGD biopsy reveals H. pylori infection, another round of antibiotics should be performed. For most ulcers, repeat EGD with biopsy should be performed around 12 weeks after therapy to monitor healing, and to reevaluate for cancer and H. pylori. Patients with refractory ulcers remain on chronic PPI therapy. Surgery can be performed in PUD with complications such as acute upper GI bleeding, perforation, obstruction and malignancy, or as the very last line of treatment of severe ulcers refractory to medical therapy.